Welcome to Breaking Point, a podcast from CAPC, the Center to Advance Palliative Care. In this limited series podcast, CAPC invites healthcare workers from across the country to share their eye-opening stories from the front lines of the pandemic. Listen as they give us an unfiltered look at their reactions to the demands they've encountered and the coping strategies they've employed as they reach their breaking point. Your host today is Dr. Diane Meier.
Hi, everybody. My name is Diane Meier. Thank you so much for joining us this week on Breaking Point. Today, we are joined by Jill Farabelli. Jill is a palliative care social worker at Penn, University of Pennsylvania Health System, at the Hospital of the University of Pennsylvania, the flagship academic hospital at Penn. What we're interested in this podcast is to gain a deeper understanding of how palliative care teams have weathered the last 2 years during the pandemic and the things that we did that were different than what we were doing in the before times, the things that we are proud of having done and hopefully wish to continue to do in the future, and perhaps things that we might do differently next time. So let me ask you to begin by just describing your team and your role on the team. And then if you could talk a bit about those things, that would be great.
Sure. Well, as you mentioned, I am one of the palliative care social workers at the University of Penn. My role is a little bit different. I'm both inpatient and outpatient. So I am also connected to our outpatient palliative and supportive oncology clinic. So I really kind of split my time between both worlds. But our team is pretty robust, as you can imagine. We have many physicians, attending physicians, we have fellows, we have a pharmacist, we have APPs, both NPs and PAs, spiritual care provider, triage nurse. So we were a pretty busy team, and our service covers 2 hospitals. So we have a sister hospital that's more kind of a community feel, but there's a physician, a social worker, and an APP that's there too. Along with my role, we have a 4-person leadership team, and I'm part of that, which is a really incredible opportunity because a lot of teams don't have a social work representing the needs of that discipline on the leadership team. And so that actually, we expanded that leadership team right before the pandemic. So about 6 months into it. So I will say from a personal experience that just really being thrown into something when the whole world feels like it's falling apart can be interesting too. And so as a leadership team, to speak to your question, I think we were challenged in many ways, like many other teams, and trying to figure out how we were going to balance this, what we were going to do, how we were going to come together as a team. And so as we did that together, there was, I think probably what I'm going to say today is not different than many other teams experienced in different ways. When we were heading into the pandemic, we really geared up and thought, okay, we're going to be getting all these consults and we're going to be super busy. And we were, but in a different way than we anticipated. So we weren't getting all the COVID calls for patients. And like, as we expected, the ICUs were kind of managing a lot of that communication on our own. Not that we weren't receiving any, but we were busy in a different way because we found that we were supporting the teams more than probably we had in the past. So I think that was a big change. One thing that we do have within our health system is a staff support coordinator who is an LCSW, and she provides support to anyone within the health system. So she's not patient facing, but she's clinician facing. And, but there's no way that she could have handled all of this. And, like many hospital systems really incorporated different mental health support resources. And we were part of that and helping to facilitate those discussions and debriefings across the health system. But I think the one piece that we really found is doing a lot of bedside counseling and support with the teams and helping them find new language and ways of communicating via virtually and telephone. And I think that's, when I talk to my colleagues at other institutions too, that's pretty much the same kind of things that we were doing that was different. And I think that part of it, I don't think any of us really want to change. We enjoyed that piece of it. And it was like this ongoing education that, extended beyond kind of the specialty or primary palliative care initiatives that we're doing, but really a personal kind of support. So I think that was one of the bigger things that changed. There was a lot of weight and complexity as we all have experienced just around the patients with COVID and all of the unknowns with it. Obviously, our team felt this certain level of moral distress and burnout related to the stressors of working and the personal stressors that were coming up. We talked extensively in group discussions and in our leadership team of how we could kind of mitigate this or manage this as it was coming up. And it was an ever evolving discussion as it changed week to week. And, what I have come to learn, I think, Diane, through all this is that there wasn't a magic solution, right? There wasn't something that we could say as to other teams or even to ourselves, like, this is the one thing that we can do that's going to work. And that's really going to help us, and that we're going to be able to not have anxiety and we're not going to feel the burnout, but trying to support each other. And just as in all relationships, the ebbs and flows, as we all respond in different ways, we all cope in different ways, and just giving each other permission to do that, I think was really important. And did we maybe do it better at other points in time? And not that we failed, of course, but I think it was a learning experience for all of us. And
so what I'm struck by in this conversation is the degree to which the focus of your work and the time spent pivoted to a great degree from a focus on patients and families, or a predominant focus on patients and families, to a focus on the well-being and function and capacity of our colleagues outside of the palliative care team. And, that's a really interesting phenomenon that I think is pretty widespread, although you guys, my understanding is, and I'm going to ask you to describe what you did to stand up the debriefings and to scale access to them. But when you think about the business case for palliative care, it's all about patient outcomes, right? Improving patient outcomes, reducing length of stay, helping people avoid emergency rooms and crisis hospitalizations. And what became abundantly clear is that there was an equal, if not greater, need to attend to the suffering of our colleagues. And we don't have a clear business case for that. Perhaps it's obvious to people that this is important given the losses of staff and the retirements and the quitting and the exhaustion. But I'm curious about how that pivot to spending a lot of time attending to the suffering of our colleagues was received both by administration as well as by our colleagues. So let me start by just asking you what you did.
Sure.
Set that up.
I mean, we still absolutely got our fair share of consults. And I think the difference was that we expected them to be so COVID related, and they inadvertently were, right? Because a lot of the support consults that we were getting were for other patients that were being impacted by the inability of visitors and stress and anxiety around all of that came with that. but you're right. Like in terms of what, the outcome piece of it, we weren't able to really make a case for it. And I think it will be interesting to see, but I think that our inadvertent and dedicated presence, where we would show up on units, right? And just say, or calling the units, how are things going? Is there something that we can do to help? And sometimes then the providers would say, actually, we have these consults that we need. And then we would spend an hour talking to them, and all of this kind of distress would come out. And so I think by just being present and showing up for them, inadvertently did have outcomes with patient care, right? They were able to take care of their patients better because they felt taken care of, and they felt that someone was hearing them, someone was also sharing in their distress, maybe on a different level, and just kind of giving them space to hear that. Now, from a health system perspective, there were lots of things that were put in place. We called ours Penn Cobalt, which was like the mental health kind of resource hub within our intranet. And there were blocks of time where people could do one-on-one sessions or debriefing groups. And we certainly even held them within our team, and had a lot of different meeting times, like staff meetings and our IVT meetings, that became a space for our team to kind of process those emotions, and maybe the transference, counter transference, as you mentioned earlier, that they were feeling related to. And we, it wasn't necessarily named that, but that's certainly what was happening.
Yeah, absolutely. So did your team also stand up and make available debriefing sessions for your colleagues?
Not formally.
Mm-hmm.
Yeah, we didn't formally, although there were some of us, I think, that volunteered with the Penn Cobalt system, and made ourselves available that way. So it was more informal that we were practicing and providing that support. Yeah, within our team, it was a little bit more formal. Like we would have different lunch with leaders, and we also have a dedicated space that happened before COVID, where our staff support coordinator would facilitate this timeout for us. So that was more formalized, but.
Got it. How much use do you think, and you may not have a window into this, your colleagues made of these various support opportunities, particularly the debriefing sessions? Do you have a sense of how well penetrated those were?
I wish I did, on some levels, but then also I really honor their maybe need for privacy and space for that. And, as you know, I'm involved with the CAPC debriefings that are held once a month. And so I was promoting that. Mm-hmm. My colleagues, I think, utilized other sessions, which I think is fine. And I hope that they did, but I'm sorry, I don't have the numbers for that. But I would overhear talking about, attending certain sessions and things like that.
Yeah. So one of the perspectives that I have comes from being at Mount Sinai during all of this. And one of the things that struck in the first couple of surges is that although there was this widespread availability of behavioral health and mental health options, people were not making use of them, because we all know about the stigma of labeling yourself as needing help, and people's fear of doing that, particularly in their place of employment. And the value of debriefing, in contrast to that, is it normalizes that it is normal to have reactions and feelings about this work, and so normal that we're going to structure time and provide a facilitator to make sure that people have the opportunity to name their feelings with others, to create really the comfort of seeing that you're not alone with these feelings. One of the stories that I heard about a debriefing done at Mount Sinai was with a bunch of ICU nurses who were obviously overwhelmed and distress by all the suffering they were seeing. And they came to this first debriefing kind of like, what is this? Why do we have to do this? This is a waste of time. And no one said much for maybe the first 5 minutes. And then finally, someone said, for the first time in my life, I'm considering leaving nursing. And the room broke open because everyone was feeling that and had not had the confidence to say that out loud. But when someone had the courage to say it out loud, virtually everyone acknowledged having those feelings and struggling with what were they bringing home to their families? What was it going to do to them over the long term, emotionally, psychologically, intellectually, the moral distress of what they were facing. And it was a really vigorous discussion. The moderator basically said nothing after that. And in the end, they were all laughing and joking about what would happen to this hospital if they all left, like it would fall apart, right? And the mood lifted 1,000% after half an hour. And none of those nurses, at least as of a couple months ago, have left. It was just powerful to see how the opportunity to speak about what they were feeling reduced the power of it. And that's different than saying, I need a psychiatrist or I need counseling personally, because the implication is that it's a personal failing as opposed to a universal structural issue that everyone shares.
Yeah, I couldn't agree more with that. And I think I have witnessed that in some of the debriefings. And what I have even tried to do it in some of those moments, and I know other facilitators do the same thing, where it feels like it's quiet, kind of opening up, and I've heard from others, and then there it is, right? That's all you need to say, and it opens wide open. And the piece that you said about the moderator or facilitator not needing to say anything, that's the best kind of session, because that means that everyone feels comfortable and feels that they're heard and that they're normal, right? This quote unquote normal. If I can go back to one thing that you said just about the offering of the debriefings, I think, and the numbers, I think in retrospect, hearing at the beginning and maybe even still sometimes that while these things are offered, people still don't feel like they have the time to do them.
Yeah.
And that is concerning and makes me sad. And I hope that changes, or that they feel like they're deserving enough of making the time to do it, and that leadership is making time for them to do it, which I do think is happening a lot more than the beginning of kind of all the frantic stuff that was happening.
Yeah, that seems really key, is to take it away from, I'm going to have to, burden my colleagues by going to this debriefing, because no one wants to overburden colleagues. I mean, that's our primary motivation, is helping one another in clinical care. And so to the extent that these sessions are essentially scheduled, just like a conference would be scheduled, and you don't have to go, but you're expected to go, that would say to people that our leadership, our administration is concerned about our well-being, wants to do something about it. Yeah. Can you tell us about your experiences either doing these or talking to colleagues who have done them? Give us some stories or some examples.
Yeah, I mean, I think I started to say a little bit there. It's some of the debriefings that I have led have, interestingly enough, at the beginning, seemed to be very kind of social work, pastoral care, chaplain attendance, that was the influx, which makes sense to me, right? Like, this is our training. We're comfortable with the discomfort. Yeah. And as palliative care providers, and I would say that in the hospital, not everyone was palliative care coming to these debriefings. And so that the stigma that you're talking about, but I think very similarly, just kind of having where one person has said something and then acknowledging what they're feeling, and then it's wide open. And maybe there was tears, maybe there was, someone shared, I remember a couple months ago, was going through a lot personally and brought it to the group. And I think that they got so much support from them that their affect and their kind of emotions at the beginning of the session really shifted. And I think watching how much the camaraderie and the community around, like, not knowing one another prior to this hour-long session, and this person shared, I, like you mentioned, I don't know if I can do this anymore. And by the end, she was kind of like, I think I can keep doing this now. Like, I know that there's people out there that care about me and that feel like I can connect with them and that understand. We certainly have heard that, myself and my colleagues, coming into our IDT meetings on Friday, where our IDT meetings are on Friday, and we have a space where we talk about cases, and we have an education and a reading and try to bring it all together. And sometimes that would end up being a place where we were sharing the interactions that we had with staff members, or what we're seeing on different units and what they're experiencing. And so that, I think, was a really, sometimes we were silent, and that was okay too. And it was just, everyone needed to breathe. But sharing how our presence maybe made an impact on some of these units, I think was really powerful for the other members of the team to hear too. And, there was we had a long-term patient, and one of our team at our community hospital actually did a tremendous amount of support for, this family, supporting this young patient who had COVID and was on all the life support measures. And it was a really long-term case. And it ended up, this family wrote a letter of gratitude to that particular person. And that goes a long way too. Like, that's when and to the team in general, to the primary team. And so just kind of holding each other's hands, metaphorically through that, was really important. And I think in many ways, our palliative care work has greater value now, because of the last 2 years, essentially. Some of it was still newer, I think, for some teams, and particularly, for the newer residents and the medical students, that this was not what they expected to step into by any means. No one did, but then being so kind of young in their career, being able to help support them and teach them what palliative care was generally, but then also how that individual support can come into play.
Yeah. I think what you're talking about actually is profound for our field, that our explicit and external self-concept is turned facing towards patients and families. And almost in spite of ourselves, because the need was so great, we've increasingly turned towards our colleagues. And I think it's going to be very important to codify that and try to think about how to measure its impact and actually structure it into our days and our workload and our staff capacity. And I think that COVID taught us that much more explicitly than I think it was more subtle before the pandemic, and now it's like everyone I talk to talks about it. So thank you for thank you for shining such a light on this. It's an innovation in terms of the obviousness of the need for it, and the very common story of palliative care teams stepping up to address that need. And it's really wonderful having a social work leader like you carrying the flag and helping the rest of us to embrace that all-important human connection with one another.
Yeah, I'm so thankful to have the opportunity. And, if I can just kind of add this, at the beginning of all of this, it was, as a social worker and as a human, trying to figure out also how to be a leader in the midst of all of this, when internally, we all feel that we're all human too, and feeling the very same things, and having to just negotiate all of these kind of managerial leadership things and triage differently, but then coming back to, but wait, we support each other. Like, we are a team here, and this is, we may have good days and bad days, but we can do this, and we got through it. And, maybe we even added like some, we had some fun things that we tried to do even virtually with, hot chocolate bars and things like that, just to like lighten things up, but to remind each other of that we are a community, and that we can support and uplift each other and hold each other up when we can't do it for ourselves.
Amen to that, Jill. Thank you so much for taking the time and being so generous
for having me
with your experience for the rest of us. I'm really grateful to you.
I'm grateful to you. Thank you so much for having me.
Thank you for listening today. For debriefings, the Emotional PPE Toolkit, and more, visit capc.org/COVID-19.